Thanks so much, and good morning. These are my disclosures, none of which are related to this presentation. So this morning, we're just going to be talking about some lesions that may require immediate or urgent intervention, as well as some that really should be left alone. The management of many of these lesions is the same. So just for review, the breast lives in a fascial envelope on the chest wall, and it's the superficial pectoral fascia which splits and has a posterior layer just anterior to the muscle and an anterior layer lying just beneath the skin. Supporting the breast are the suspensory ligaments of Cooper, the Cooper's ligaments that are connective tissue and that bind the fat lobules, and you can see very easily on mammography as well as with ultrasound. Cut at various depths are the segments, the breast duct and lobule segments, which you can see here, and where many of these processes, the inflammatory processes, begin, as well as other diseases of the breast, are in the terminal duct lobular unit or the surrounding stroma. So a very fine book came out, many years ago. It's now in its third edition, published by Elsevier in 2009. It's Mansell and Webster, Benign Breast Disorders. And a classification of benign breast disorders was presented with an acronym, ANDI, whose letters stand for aberrations of normal development and involution. And this classification takes you throughout life. So the early developmental stages, the teen years through 25, where you find fibroadenomas and at pubescence sometimes, adolescent hypertrophy, which can be unilateral. Then cyclical changes of the adult during the reproductive years from 25 to 40, breast pain, nodularity, epithelial hyperplasias of pregnancy as the breast enlarges under endocrine stimulation. Involution, I am sorry to tell you, begins at the age of 35 and continues on for another 20 or 25 years with all of these structures within the breast affected. So you'll find cyst formation and as a terminal duct lobular unit type of lesion, sclerosing adenosis. And then within the ducts, you'll find enlargement and then periductal mastitis, which can be painful and require the treatment that we apply for other inflammatory lesions. Epithelial turnover is also common there, where you would have hyperplasia progressing in some instances to atypias, epithelial atypias, which need intervention, and then going on and not addressed in this book to malignancies. Non-ANDI conditions we are most concerned with here. They have well-defined etiologies unrelated to the time of life, and lactational abscesses are common. So the literature is really pretty poor as you try to review it, and the best review that I've seen, and it's now aging a little bit, it was published in Radiographics in 2011. It came from Montreal, and Isabelle Trope was the first author. So this is about breast abscesses, and the illustrations are excellent. The comment that's made here, and this was the introductory paragraph, and it's something to take home, is that the available literature on treatment of breast abscesses is imperfect. A lot of it is ad hoc, and no clear consensus exists on drainage, antibiotic therapy, and follow-up. So one's experience goes very much into what we do with these patients. So emergent or urgent, for patients, breast symptoms are all urgent. There's redness and swelling, ecchymoses and discolorations, ulceration with or without drainage, enlarged painful axillary lymph nodes, which occur with inflammatory processes, as well as breast cancer, and we have to be very careful with these to keep in mind that there is lurking always an inflammatory breast cancer, advanced breast cancer, mimicking the breast abscess. Fever, focal pain, and some duct discharges bring these patients in. So how do they come to us, and from where? So the patients may come from the obstetrician's office, a lactating patient with a problem, from the surgeon who has just treated that patient for cancer or has performed a cosmetic procedure or reconstruction, and the oncologist, either medical and or radiation, who has immunosuppressed that patient. We also may find coming to us directly those patients who suffered a traumatic episode. So we need to be available and ready to address these problems. How do we evaluate these patients? The history, including timing, is first, when did the trauma occur? What was it? How did it happen? Pregnancy or lactation, and recent or remote surgery. All these histories are what you would take with any patient. Diabetes or immunosuppression, and then some risks of development of inflammatory processes, including abscesses, smoking, and that's a big risk factor. I think it's unrealized, and then piercings, including nipple ring placements. Physical exam, first observe the patient, look at the breast. The patient may have a cord in the upper outer quadrant representing mandors, and there's nothing much you need to do. It's a self-limited condition. Or you may see evidence of mastitis in redness and swelling. And try to do a physical exam, and there you'll see just how acute the problem is by how close the patient lets you come. So masses, no masses, whatever you find from the ultrasound examination, and will guide you towards the appropriate therapy. So with ultrasound, make certain that you look in the area that's symptomatic, but extend your field around it, because frequently there are extensions of abscesses. The collections may infiltrate the surrounding tissue, and make certain too that your depth of field includes the pectoral muscle so that you don't miss a deep lesion. Is an intervention necessary? That's the next question you ask yourself. And in the case of lactational abscesses and other patients who have clinical findings of an inflammatory process, it's usually abscess versus mastitis. So let's look at the image on your right, which is a patient who was asymptomatic, she may have had something on her contralateral breast, but here is a very normal picture of the tissue of a young patient who would have mammographically dense breasts. There is a thick layer of echogenic fibroglandular tissue. The comparative tissue, the tissue relative to which your echogenicity is compared, is fat, which is less echogenic. So this is normal, and this tissue, you can see evenly the very fine ductal structures winding their way through. They are a fraction of a millimeter in diameter. You can see also the pectoral muscle deep to it, and everything looks orderly. Compare this with a lactating patient who is in pain, has redness and swelling on her breasts. the area of fibroglandular tissue, and the tissue looks less echogenic and more hypoechoic during lactation itself. But this is becoming disorderly looking. This patient then left, and there's no abscess here. There is just not poor penetration deeper. These ducts are going in various directions. The patient left with a prescription for antibiotics, which she took for 7 to 10 days. And here's, again, the same thing on the left. 2 months later, at the conclusion of the antibiotics, she thought things had resolved. But now we have a very large abscess collection with a lot of detritus within it and surrounding response. These are what you might use to introduce if you use an introducer for a breast biopsy needle. But for an abscess of this size, you could use this, remove the stylet, attach tubing, and then a syringe at the end of the tubing, and try to aspirate the fluid. These are stiff, and as metallic areas, they probably are less likely to occlude with the material that you're withdrawing. But it's just one of many ways to do the abscess drainage. This diagram comes also from that book on benign breast disorders, and the most common locations are what you see here: a subcutaneous abscess in fat bulging the tissue, a subareolar abscess that may not be related to lactation, or may be, and then here within the parenchyma of the breast, and many lactational abscesses will occur here. There is some fear about milk fistula after aspiration. We've seen very few of those. And then the deep ones. So it's important to look deep and make certain that you don't have a retromammary abscess that is actually proceeding through the muscle. Mastitis can progress, as I've shown you, to abscess despite antibiotics, so these patients need to be followed up. They have varied ultrasound appearances. Most common is to find them during the first month of lactation and at weaning. The entry of the pathogen, which is most often Staph aureus, is through a cracked nipple. The method of therapy is also most often ultrasound-guided serial drainages. You can place self-retaining catheters, usually 6 or 8 French, but the serial drainages seem to be just as effective. They're less invasive, with less scarring, and less patient concern with catheter management, and easier for them to continue breastfeeding. They were very popular after a review or a report came out from Scandinavia about using catheters for abscesses that were greater than 3 centimeters in diameter, which is actually a very small, not a very large abscess collection, but they are losing favor in most breast centers. Surgical incision and drainage is no longer standard of care, and this is acknowledged by surgery as well as our own experience, which supports percutaneous drainage. For treatment failures after repeated drainages, it's appropriate to call for surgical consultation, as well as with extensive multiloculated collections. When you begin to aspirate, you can break septa by moving your needles around. So the multiloculated, or some locules, can be aspirated percutaneously, but some may not. Or if the abscess has ruptured through the skin already, it can be completed with surgical incision and drainage. This photograph shows you a lactational abscess, which may be about to break through the skin here, and on the areola, the cracked area of skin through which the the pathogen entered. The areolar pigment had changed during pregnancy, as we find not uncommonly. In Mansell's report about abscesses, it is said that 9% of breastfeeding women will experience an abscess. Some images here. This is an example of what you might see commonly of an abscess. It's beginning to wind its way into the subcutaneous fat. It has some heterogeneous material at its base. Through transmission, you see. The abscess itself extends laterally. You may think it ends here, but it doesn't. It ends here. The question is, and this is a trapezoidal opening of your image, is there another collection adjacent to it which is contiguous with this? And do you need to extend your procedure? So important to continue your study before you begin the procedure to include areas around the abscess in all directions. Another abscess, this is unilocular, these are orthogonal views, and I'm showing you this to show you the common pattern, a vascular pattern, which is rim vascularity around an abscess. This one was easily drained percutaneously. Another appearance is a more solid appearance. And what you can see here is this we published in BIRADS with its very pretty, it came from Italy, submitted by Giorgio Rosato, who is an Italian radiologist who subspecialized in breast ultrasonology. And here you find this beautiful rim abscess. But is the content solid? Is it liquid? It had thick material that was difficult to aspirate and sometimes incompletely aspirated, but possible. A colleague in a much more recent case, working with a fellow, addressed this as a solid lesion. The patient was 20. She was not lactating, and I don't know whether she had a piercing or nipple rings or what have you, but this was a scout image for a core biopsy that they planned. Yes, it was the same kind of material that was found in this smaller abscess and possibly drainable. This was not recognized as fluid anteriorly. The histology of the core biopsy was acute abscess with nothing else. So things can look that way. How do you image large lesions? Either panoramic sweeps, extended fields of view, supine automated ultrasound, and I'll show you a couple of examples, are great for multiple extensive bilateral processes, but they don't work for the don't touch me, very excruciatingly painful abscesses. You need compression of a paddle, and you can't, just as you can't do mammography, even though the compression is far less with ultrasound, it is too much for these patients who are difficult to touch. Splicing method with dual screen and where you oppose the two edges. Trapezoidal display is another one which I showed you. And then you may need a lower frequency transducer for penetration of very thick tissue or to get back to the pectoral muscle. This is a 9-centimeter abscess, also percutaneously drained, being seen with the panoramic sweep. So what are the pathogens and some of the antibiotics that are used? Staph aureus, as I mentioned. Others may include MRSA, methicillin-resistant staph, Streptococcus pyogenes, E. coli, Bacteroides, and then a variety of antibiotics. I should say that some of the slides are not in what you have for this lecture. Some you do, but if anyone wants any of these or all of them, just let me know, and I'll be glad to send you the presentation. So these are the current antibiotics that are used. Just note that for MRSA, clindamycin, which seems to be used wantonly by most obstetricians, is effective against methicillin-resistant staph. So the therapeutic procedure: confirm the abscess with ultrasound. Antibiotics are important, but you can aspirate and drain before antibiotic therapy is instituted. Used to be thought that you needed coverage while you were doing the procedure, but you really do not. It's important to get the pus out of the abscess, and then the antibiotics can be instituted. Written consent: cleanse the area with a sterile field, drape it, and then however you prepare and disinfect your transducers before use is what you need to do. There's no need to sheath these transducers. You have a sterile field, and the needles, whatever needles you are using, should never touch the probe for any procedure. Lidocaine, 1 or 2%. 2% actually works a little bit better in these patients. Make a 1 milliliter can be placed into a skin, creating a wheel with a tuberculin syringe. These are syringes that hold about a milliliter with needles that are a ½ inch in length, very fine needles, 26 or 27 gauge. And through the skin wheel, you can use a larger needle to inject 10 ml or more of lidocaine around and in the cavity. You can aspirate a few ml for gram stain and culture and sensitivity. It's very important to do that. If there's no pus or other liquid and you want to consider biopsy, do so, but at least send whatever you can for analysis. Aspirate or drain, usually with a 16 gauge or an 18 gauge needle with tubing if it's a large abscess. If not, a syringe will do. If the material is very thick, you can use a 12 or a 14 gauge needle and syringe or introducer, as I've mentioned before. There have been a report or two, and we did try it with limited success, using a vacuum device in non-cutting mode. You need a wired device there, but for a very large abscess or one that's quite thick, that might be something you might want to try. For large abscesses, this trocar approach can be used to place a 6 or 8 gauge French self-retaining catheter. And once you've emptied the cavity, you can rinse it with sterile saline until the saline returns fairly clear. It takes quite a long time to empty some of these abscesses, as I'm sure some of you know. Then, when you finish the procedure, notify the referring physician and arrange for antibiotics if not already started. Check gram stain and culture to see if there's need to change what has been the initial antibiotic given to the patient. The patient can continue to breastfeed from the unaffected breast and empty and pump the affected breast to keep it as free of milk as possible. The milk is a good culture medium, and stasis really is one way that you can develop abscess. So these are some of the most commonly used antibiotics, but any of the obstetricians, and you can prescribe it in conjunction with the referring physician if you would like. The galactocele is something that you find in many lactating patients. It's not urgent, it's variable images on ultrasound assist with layering complex mass representing an oil cyst or fat necrosis, or a solid appearing mass. On mammography, sharply defined rounded fat density mass with small soft tissue density nodules. They don't calcify, and mammography can show you additional lesions that are not palpable. This is a typical appearance of a couple of galactoceles. one sitting right on top of the other with the little nodules that I described to you. If you aspirate these, you'll get back milk. Is it necessary to aspirate any or all of them? Probably not. Post-lactational involution is something to know about. Lactation will cease 7 to 10 days after breastfeeding has stopped, with phagocytosis removing the accumulated secretory products. When would a patient who is of screening age be able to return? In 3 to 4 months. And the resting state will come back. There'll be an increase in fat in the breast. The breast will be less dense after involution. If there's need for mammography during the period of lactation, the patient should empty your breast either through feeding or pumping, and if it's not a worthless exam, you can see calcifications if necessary, and a variety of other things. Post-surgical collections, high-risk patients, infected cysts, and then ductectasia-related lesions are also possible. There is a process called granulomatous mastitis, which is a subacute, chronic, hard to treat, and I'll show you an example. This is ductectasia, an abscess, often recurrent. Here, aspirate, culture and sensitivity. This duct is filled with pus, and there's edema in the surrounding tissue. They may recur frequently and require surgical excision, and even after that, recur. Around a foreign body, as I think we know in other areas, you may have abscess formation. This patient who had a left mastectomy and chest wall radiation also had a valve replacement which required a median sternotomy, and the abscess, which is going from the sternum, here's the edge of the sternum and the sternal tissue behind it, the sternal bone, going from the posterior aspect all the way through the skin where it was draining, so there's a fistulous tract. Other lesions, possibly urgent, may be related to trauma, falls, seatbelt injuries, large hematomas, fat necrosis, scarring. For most of these, no intervention is necessary, and you treat them symptomatically. Those patients may come to the ER. Vascular lesions are Mondor's, which I mentioned, superficial venous thrombosis, and then maybe once a year, if your volume is high, or possibly twice, you'll find a pseudoaneurysm after stereobiopsy. I'll show you 2 cases of these. And then don't forget inflammatory carcinoma. Here is a leave me alone lesion. This is a post-surgical seroma 6 months after lumpectomy and radiation therapy in a 79-year-old asymptomatic patient. The mammogram that corresponds shows you this fluid collection, and it's starting to show spiculation around the edges. This is the scarring that will occur slowly after the fluid is resorbed over a period of time, which may be a couple of years. So this, don't touch. If there's an axillary sampling or a dissection and a fluid collection is there, that is generally drained by the surgeon, as you see here. Here's another leave me alone lesion. This is an epidermal inclusion, and these are just beneath the skin, subdermal, and sebaceous cysts. If you needle those to remove the contents, there will be an extrusion of material, which is very irritating and may cause abscess formation. If this is something that bothers the patient, it can be excised surgically along with the capsule. So those are not for us to do. This is Mondor's. It's a thrombosed vein. You can see it beating here, and the axial view of it, and the vascularity, which is not there. So these are self-limited. They need to be followed up for resolution, and usually in 3 to 4 weeks, if there's pain, symptomatic relief is what you can offer. This is a pseudoaneurysm after a stereotactic biopsy, and generally they can be thrombosed after you stand there and compress vigorously for 15 to 30 minutes. It may take longer than that, and if it does take more than an hour or so, give the surgeon a call. Here, this is the last case I'm showing you. This is inflammatory carcinoma. And what this is automated ultrasound with a 15 cm wide transducer. It's a linear transducer that acquires the image with reconstructions in coronal view where you see the entire breast at that level, and a sagittal reconstruction. So looking at this, you see the pot orange very nicely, the dilated pores and the swollen breast tissue. Looking at the acquisition, the very thickened skin, it's more than 1 millimeter in thickness, and possibility of masses within the breast parenchyma, which you do see better and confirm on the sagittal reconstruction. So this is inflammatory carcinoma, and yes, you can biopsy these masses, possibly do a skin punch biopsy for the diagnosis, and if you make a mistake and send the patient home on antibiotic therapy, you won't be able to drain anything, but if you send the patient home, she may feel better, but she will be back to you, and you make sure that you see her within a week to 10 days, and the right thing will be done. So in conclusion, these are my take-home messages regarding emergent breast ultrasound. Symptomatic lactating patients should be seen emergently and evaluated with ultrasound. If mastitis is diagnosed, antibiotic therapy and ultrasound follow-up in 7 to 14 days is important. If an abscess is found, make certain that you send fluid for gram stain, culture and sensitivity, and then attempt to empty it. Post-surgical fluid collections in lumpectomy and radiation therapy treated asymptomatic cancer patients are leave-me-alone lesions, as are the dermal lesions that I mentioned. First-line treatment of breast abscesses, this is important, and it's accepted by surgeons as well as breast imagers, is no longer surgical IND. But know when surgical intervention is necessary, and don't forget inflammatory carcinoma as an insidious mimic of breast abscesses, and I thank you very much for being here.